Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the thoracic wall. In this lecture, we'll be discussing the bones, the muscles, and the innervation, and even the blood supply of the thoracic wall. And I'll be back later for a clinical correlation and the end of session quiz. But for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
Perhaps you've come to a point in your life where, when you encounter a word that ends in the letter X, you become suspicious that it may have a Greek origin. Well, in the case of the word thorax, such suspicions would be entirely justified. Thorax originally referred to the ornate chest plates worn into battle by the ancient Greeks. Just how ancient were the ancient Greeks? I don't know, but I do know this. The thorax, in modern times, refers to the area of the human body between the neck and the abdomen. This solid anatomy lecture will cover the bones, muscles, nerves, and blood vessels of the thoracic wall. The bones of the thoracic wall form the so-called thoracic cage, which protects the viscera of the thorax and upper abdomen, assists respiration, and provides attachment points for muscles acting on the upper extremity and for muscles of the abdomen, neck, and back. The bones contributing to the thoracic cage are the sternum, 12 pairs of ribs and associated cartilages, 12 thoracic vertebrae, and the intervertebral discs between them. These are all components of the axial skeleton. The thoracic cage is attached to the appendicular skeleton via the sternoclavicular joint, which is the articulation between the manubrium of the sternum and the clavicle. This association will be investigated further in the solid anatomy lectures on the upper extremity. Ribs have costal cartilage extending from their distal ends that connect them to the sternum. The costal cartilage of rib 1 forms a primary cartilaginous joint, or synchondrosis, with the manubrium of the sternum. All of the other joints formed between the costal cartilages and the sternum are synovial joints. The ribs articulate posteriorly with the thoracic vertebra, forming synovial joints with their bodies and transverse processes. Thus, the only non-synovial rib joint is between the costal cartilage of the first rib and the manubrium. Anatomists classify ribs into 4 categories. Ribs 1 through 7 are called true ribs because their costal cartilages articulate directly with the sternum. Ribs 8 through 12 are called false ribs because their costal cartilages either don't articulate with the sternum at all, as in the case of ribs 11 and 12, or their costal cartilages reach the sternum by merging with the costal cartilages of ribs superior to them, rather than articulating with the sternum directly and independently. The costal cartilages of ribs 7 through 10 merge to form the costal margin. In addition to being false ribs, ribs 11 and 12 also belong to the floating rib category, since their costal cartilages are not connected to the sternum. There is a 4th category of ribs, the typical ribs, which will be discussed in a moment. Perhaps you're asking yourself, why do we have rib joints? Why are the ribs not just fused to the sternum and the vertebral column, forming a sturdy, protective shell around the thoracic viscera? The joints allow for more mobility of the trunk, allowing for such actions as bending, twisting, and reaching. Also, as is discussed in the solid anatomy lecture on respiration, elevating and depressing the ribs assists in respiration. The distinguishing characteristic of a thoracic vertebra, the one characteristic that no cervical and no lumbar vertebra has, but that all thoracic vertebrae have, is articular facets on the bodies and transverse processes for the synovial joints formed with the ribs. The typical ribs, which are ribs 3 through 9, all have a head, a tubercle, and a neck between them. The remaining portion of the rib is the body, which begins curving at the angle of the rib. On the inferior border of the inner surface of a typical rib, there is a costal groove where the intercostal neurovascular bundle runs. Typical ribs articulate with the thoracic vertebra in a definitive manner. The tubercle of a typical rib articulates with the transverse process of the thoracic vertebra at the same level as the rib. For example, the tubercle of rib 5, which is a typical rib, articulates with the transverse process of the 5th thoracic vertebra. The head of a typical rib articulates with the body of the vertebra at the same level as the rib and the body of the vertebra that is one level below the rib. For instance, the head of typical rib number 7 forms a synovial joint with the bodies of thoracic vertebra 7 and 6. The 3 segments of the sternum are, from superior to inferior, the manubrium, the body, and the xiphoid process. The anatomist or anatomists who named the parts of the sternum felt as though it resembled a sword. Manubrium is the Latin word for handle of a sword, while xiphoid, as you may have gathered from the presence of the letter X, is a Greek word that means sword-shaped. On the superior surface of the manubrium is the jugular notch. The line of articulation between the manubrium and the body is called the sternal angle, or, occasionally, the angle of Lewis. The line of articulation between the body and the xiphoid process is the xiphisternal junction. There are primary cartilaginous joints, or synchondroses, at the sternal angle and the xiphisternal junction. The costal cartilage of rib 2 articulates at the sternal angle. The costal cartilage of rib 7 articulates at the xiphisternal junction. And the costal cartilages of ribs 3 through 6 articulate with the body of the sternum. The superior thoracic aperture, or thoracic inlet, is the bony opening between the neck and the thorax. Its borders are the jugular notch superiorly, the first rib laterally, and the body of the first thoracic vertebra posteriorly. The bony opening between the thorax and the abdomen is the inferior thoracic aperture, or thoracic outlet, which is bordered anteriorly by the xiphisternal junction and the costal margin, laterally by the 12th rib, and posteriorly by the body of thoracic vertebra 12. The muscle filling the inferior thoracic aperture is the diaphragm. A series of vertical lines may be visualized that assist in describing the location of thoracic structures with respect to the thoracic wall. The mid-sternal line runs from the jugular notch to the tip of the xiphoid process. The mid-clavicular line runs inferiorly from the midpoint of the clavicle and intersects the nipple on the male at the 4th intercostal space. Intercostal spaces are numbered in accordance with the rib superior to them. The mid-axillary line is found at the middle of the axilla, or armpit, so it runs along the middle of the ribs on the lateral thoracic wall. The mid-scapular line is found posteriorly, running through the midline of the scapula.
It's time for a clinical correlation. Now, before we move on to discuss the muscles of the thoracic wall, I want to talk about a common reason for chest pain called costochondritis. What happens in costochondritis is the point at which the costal cartilage meets the sternum, you get this inflammation, and that inflammation can be very painful. Now, this normally is the result of either physically straining the points of attachment or an injury such as a blow to the chest after a motor vehicle accident. The pain with costochondritis should be reproducible by palpating over the costosternal junction sites. So your exam skills can really come in handy when diagnosing costochondritis. Now, something as simple as palpating the chest wall can be helpful to identify the reason for a patient's chest pain. Now, this is especially helpful because often musculoskeletal causes of chest pain, like costochondritis, can mimic cardiorespiratory causes of chest pain as well. So that answers these questions here. What is costochondritis? Remember, this is the inflammation of the costosternal junctions. And then also, what exam is helpful to diagnose costochondritis? That's palpating the costosternal junctions. You just give them a good squeeze just like that. All right, guys, it's time to move on to that lecture.
The muscles filling the intercostal spaces are conveniently named the intercostal muscles. None of the 3 layers of intercostal muscles completely fills the intercostal space from the sternum anteriorly to the vertebral column posteriorly, but they overlap in such a manner that there are no gaps in the musculature of the spaces. In each of the 11 intercostal spaces, the most superficial muscle is the external intercostal, which runs from about the tubercle of the rib to the midclavicular line. At this point, the muscle ends, but the layer continues as a membrane, which reaches the sternum. Deep to the external intercostal is the internal intercostal muscle, which begins at the sternum and becomes membranous at about the mid-axillary line. The deepest intercostal muscle is the innermost intercostal, which is muscular through the middle of the intercostal space, but membranous anteriorly and posteriorly. If you are asked to distinguish the external from the internal intercostal muscles in the laboratory, a good way to tell them apart is by observing their fiber angles. If you place your hand in your pants pocket, your fingers are running in the direction of the fibers of the external intercostal muscle. If you put your hand on your face, your fingers are running in the direction of the fibers of the internal intercostal muscle. The fibers of the innermost intercostal muscle run more vertically than the fibers of the internal intercostal, but can be difficult to distinguish based on fiber orientation. The best way to tell these 2 muscles apart is by locating the intercostal neurovascular bundle, which runs between them. The intercostal neurovascular bundle is especially prominent on the inner surface of the posterior thoracic wall once the membrane, or pleura, overlying it has been torn away. Here, the neurovascular bundle can be seen disappearing under the posterior edge of the innermost intercostal muscle. Also present on the inner surface of the posterior thoracic wall are the subcostal muscles, which are found at the same level as the innermost intercostal muscles. The 11 external, internal, and innermost intercostal muscles each fill a single intercostal space, but the subcostal muscles span more than one intercostal space. The intercostal and subcostal muscles keep the intercostal spaces rigid during respiration, which will be discussed further in the Solid Anatomy lecture on respiration. On the outer surface of the posterior thoracic wall, deep to the superficial back muscles, but superficial to the erector spinae, are the serratus posterior muscles. The serratus posterior superior originates from the spinous processes of vertebra C6 to T3, give or take a level, and runs inferiorly to insert on the 2nd to 5th ribs. The serratus posterior inferior originates at the spinous processes of thoracic vertebra 11 or 12 and from the thoracolumbar fascia, and runs superolaterally to insert on ribs 9 through 12. The serratus posterior muscles are involved in elevating and depressing the ribs during respiration. On the inner surface of the anterior thoracic wall, the transversus thoracis muscle consists of a series of slips of muscle that originate on the body and xiphoid process of the sternum and run superolaterally to insert on the 2nd through 6th costal cartilages. This muscle probably plays a minor role in respiration, possibly depressing the ribs during expiration. The somatic nerves of the thoracic wall originate from the spinal nerves of levels T1 through T11. The dorsal rami of these spinal nerves provide motor innervation to the intrinsic muscles of the back, such as the erector spinae, in a segmental myotomal pattern, and sensory innervation to the skin of the back in a segmental dermatomal pattern. Recall that a myotome is the segment of muscle supplied by a single spinal nerve, and a dermatome is the area of skin supplied by a single spinal nerve. With the exception of the part of T1 that joins the brachial plexus, the ventral rami of thoracic spinal nerves do not combine to form plexuses as the ventral rami of cervical spinal nerves do. Instead, they remain independent and run in the intercostal spaces along the inferior edge of the ribs, forming the superior border of the intercostal space. For instance, the ventral ramus of T7 runs along the inferior border of rib 7. The ventral rami of T1 through T11 are referred to as the intercostal nerves, except for the part of the ventral ramus of T1 that joins the brachial plexus. The intercostal nerves run with the intercostal vessels between the innermost and internal intercostal muscle layers. The ventral ramus of T12, which is called the subcostal nerve, but is not related to the subcostal muscles, travels along the inferior border of the 12th rib. But if you're a fan of plexuses, don't despair. The ventral rami of lumbar spinal nerves combine to form the lumbar plexus, which will be discussed in detail in the Solid Anatomy lecture on the posterior abdominal wall and viscera. The intercostal nerves provide motor innervation to the 3 overlapping intercostal muscles, the subcostal muscles, the serratus posterior, superior, and inferior, and the transversus thoracis. You may find yourself asking why the thoracic ventral rami are innervating muscles associated with the axial skeleton. Perhaps you're recalling a fundamental rule of neuroanatomy, which states that ventral rami innervate appendicular muscles, or muscles associated with the limbs, while dorsal rami innervate axial muscles, or the intrinsic back muscles. The key to this apparent dilemma is, of course, embryology. In the embryo, the muscles of the thoracic wall develop from the hypomere, which is the portion of the myotome that is innervated by the ventral rami. Thus, even though these muscles act only on the axial skeleton, that is, the ribs, they are innervated by ventral rami rather than dorsal rami. The intercostal nerves also provide sensory innervation to the skin on the thoracic wall in a segmental manner. The 2 main sensory branches of the intercostal nerves are the lateral and anterior cutaneous nerves. The lateral cutaneous nerves originate at about the mid-axillary line, pierce the internal and external intercostal muscles, and pass between the slips of the serratus anterior muscle to reach the skin. The anterior cutaneous nerves branch off of the intercostal nerves just lateral to the sternum and pass through the internal intercostal muscles and the membrane of the external intercostal to reach the skin. The 7th through 11th intercostal nerves cross the costal margin anteriorly to reach the abdominal wall. At this point, their name changes from intercostal nerves to thoraco-abdominal nerves. They continue inferomedially across the anterior abdominal wall and provide segmental cutaneous innervation and motor innervation to abdominal muscles such as the rectus abdominis. A pair of dermatomal landmarks worth remembering are the nipple in the male, which is included in the T4 dermatome, and the umbilicus, which is at the level of the T10 dermatome. There is actually considerable intersegmental overlap in the motor and sensory innervation of the thoracic and abdominal walls. Therefore, complete paralysis of a myotomal segment or complete anesthesia of a dermatomal segment will not occur unless the spinal nerve that serves that segment, as well as the nerves above and below it, are cut. If you've watched the Solid Anatomy lecture on the deep back and the spinal cord, you may recall that the gray matter of the spinal cord forms ventral horns, which are the locations of the cell bodies of the lower motor neurons, and dorsal horns, which are the locations of the cell bodies with which the peripheral sensory neurons arriving through the dorsal roots synapse. Along the thoracic levels of the spinal cord and into the first and sometimes second lumbar level, there is also a lateral horn of the gray matter that is formed by the intermediolateral cell columns, where the cell bodies of presynaptic sympathetic fibers are found. You may recall from the Solid Anatomy introductory lecture that the nervous system can be functionally divided into a somatic and an autonomic nervous system, and the autonomic nervous system can be further divided into a parasympathetic and a sympathetic nervous system. The parasympathetic system was said to be craniosacral because the parasympathetic nerve fibers emerged with 4 of the 12 cranial nerves and from the sacral spinal cord as the pelvic splanchnics. The sympathetic system was characterized as thoracolumbar because it arises from the thoracic levels and the first and sometimes second lumbar levels of the spinal cord. The preganglionic, a term synonymous with presynaptic, sympathetic nerve fibers leave the lateral horn of the gray matter via the ventral roots, which join with the dorsal roots to form spinal nerves. The sympathetic fibers leave the vertebral column through the intervertebral foramina with the spinal nerves. When the spinal nerves bifurcate into ventral and dorsal rami, the sympathetic fibers follow the ventral rami, which include the 11 intercostal nerves, peripherally. The sympathetic fibers leave the ventral rami to join the sympathetic trunks by passing through connections called white rami communicans. Singular would be white ramus communicans. The bilateral sympathetic trunks run vertically along the posterior thoracic wall lateral to the vertebral bodies. The sympathetic trunks have paravertebral ganglia at each level where the cell bodies of the postsynaptic sympathetic fibers are located. The sympathetic trunks extend superiorly into the neck and inferiorly into the abdomen and the pelvis. Once a preganglionic sympathetic fiber reaches the sympathetic trunk, it may follow one of 3 courses. If the target organ is in the head, such as the dilator pupillae muscle, a muscle of the eyeball that is involved in dilation of the pupil, the sympathetic fiber will ascend through the cervical sympathetic trunk in the neck. The sympathetic fiber will synapse at the superior cervical ganglion, which is the site of the cell bodies of all postganglionic sympathetic fibers destined for target organs in the head. The superior cervical ganglion, which is usually longer than the other ganglia in the sympathetic trunk, is located at the level of the 2nd and 3rd cervical vertebrae. The postganglionic sympathetic nerves then follow the carotid arteries and their branches into the head to reach the target organ. If the target organ is a blood vessel, an erector muscle of a hair follicle, or a sweat gland in the trunk or the limbs, the sympathetic fiber will ascend or descend or stay at the same level of the sympathetic trunk to reach the appropriate level according to the location of the target organ. It will synapse at one of the paravertebral ganglia found along the sympathetic chain. Postsynaptic sympathetics then pass through a gray ramus communicans, which connect the sympathetic trunks to the ventral rami. The postsynaptic sympathetics follow the ventral ramus to the target organ. Sympathetics are involved in vasomotion, pilomotion, and pseudomotion. Specifically, these actions are contraction of the smooth muscle of the blood vessels, or vasoconstriction, erection of the hair follicles, resulting in goosebumps, and stimulation of the sweat glands, resulting in sweating. If the target organ is part of the abdominal viscera, the sympathetic fiber will descend the sympathetic trunk without synapsing and continue through an abdominopelvic splanchnic nerve. These are the greater, lesser, and least splanchnic nerves, which carry preganglionic sympathetic fibers from spinal cord levels 5 through 9, 10 and 11, and 12, respectively. The splanchnic nerves leave the sympathetic trunk and run inferomedially. They pass under the diaphragm to reach the abdomen and synapse at the prevertebral ganglia associated with the abdominal aorta. Further discussion of the greater, lesser, and least splanchnic nerves will be found in the solid anatomy lectures on the abdomen. The blood supply of the thoracic wall is provided by the 9 anterior and 11 posterior intercostal arteries, which run in the intercostal spaces just superior to the intercostal nerves, and which anastomose with each other, usually between the mid-axillary line and the mid-clavicular line. The first 6 anterior intercostal arteries arise from the internal thoracic arteries, which are branches of the subclavian arteries. The origin of the subclavian arteries from the aorta will be discussed in the solid anatomy lecture on the mediastinum. The internal thoracic arteries enter the thorax from the neck by dropping through the superior thoracic aperture. They run vertically along the inner surface of the anterior thoracic wall, just lateral to the sternum, between the transversus thoracis and the costal cartilages. At about the level of the 6th intercostal space, the internal thoracic artery bifurcates into the superior epigastric artery and the musculophrenic artery. The superior epigastric artery continues inferiorly to reach the anterior abdominal wall. The musculophrenic artery travels inferolaterally, gives off the inferior 3 intercostal arteries, and supplies the superior surface of the diaphragm muscle as well. The first 2 posterior intercostal arteries are branches of the superior intercostal artery, which is a branch of the costocervical trunk, another proximal tributary of the subclavian artery. The inferior 9 posterior intercostal arteries arise from the thoracic aorta. The thoracic aorta rests on the vertebral bodies and proximal parts of the ribs to the left of the midline on the posterior thoracic wall. So the right intercostal arteries are longer than those on the left. The esophagus, thoracic duct, and azygos vein run along the posterior thoracic wall parallel to the aorta and adjacent to its right side. So the right posterior intercostal arteries pass posterior to these structures as they course towards the intercostal spaces. Since the most inferior anterior intercostal artery is found in the 9th intercostal space, the 10th and 11th intercostal spaces are supplied entirely by the 10th and 11th posterior intercostal arteries from the thoracic aorta. There is also a bilateral branch from the thoracic aorta that runs along the inferior aspect of the 12th rib, which, like the nerve running just inferior to it, is called subcostal rather than intercostal. The intercostal spaces are drained by the 9 anterior and 11 posterior intercostal veins, which run in the intercostal spaces just superior to the intercostal arteries. The superior 6 anterior intercostal veins drain into the internal thoracic veins, which drain superiorly into the brachiocephalic veins. The left and right brachiocephalic veins merge to form the superior vena cava, which will be described in further detail in other solid anatomy lectures on the thorax. The inferior 3 anterior intercostal veins drain into the musculophrenic vein, which merges with the superior epigastric vein at about the level of the 6th intercostal space to form the internal thoracic vein. Most of the posterior intercostal veins drain into the azygous system of veins. To the right of the aorta, and running parallel to it, on the posterior thoracic wall, the azygous vein receives the right posterior intercostal veins directly from the 5th through 11th intercostal spaces. The azygous drains superiorly into the superior vena cava and inferiorly into the inferior vena cava in the abdomen. The 2nd through 4th right posterior intercostal veins drain into the right superior intercostal vein, which drains into the azygous superiorly. The first right and left posterior intercostal veins drain either directly into the brachiocephalic veins or into the vertebral veins, which drain into the brachiocephalic veins. The 2nd through 4th left posterior intercostal veins drain into the left superior intercostal vein, which drains into the brachiocephalic vein. The remaining 7 left posterior intercostal veins drain into the highly variable hemiazygous and accessory hemiazygous veins, which are found just to the left of and running parallel to the thoracic aorta. The accessory hemiazygous is located superior to the hemiazygous vein. The hemiazygous and accessory hemiazygous veins both drain across the midline into the azygous vein and may have connections to other veins in the thorax and the abdomen. The subcostal vein, which runs along the inferior aspect of the 12th rib, drains into the azygous vein on the right side and the hemiazygous vein on the left. The order of the components of the intercostal neurovascular bundle in the costal groove of the rib from superior to inferior is vein, artery, and nerve. Thus, a popular mnemonic to remember the order of these structures is VAN. V for vein, A for artery, and N for nerve. This neurovascular bundle passes posterior to the innermost intercostal muscle at about the level of the angle of the rib. A collateral intercostal neurovascular bundle, consisting of branches from the intercostal neurovascular bundle, begins at about the level of the angle of the rib and runs along the superior edge of the rib, forming the inferior border of the intercostal space. The order of the structures in this bundle, from superior to inferior, is also vein, artery, and nerve. A final tip. Remember that there are anterior and posterior intercostal veins and arteries, but there is only one intercostal nerve running in each intercostal space. There is no anterior intercostal nerve or posterior intercostal nerve, just the intercostal nerve, which is a ventral ramus of a thoracic spinal nerve. Now, with the walls of the thoracic cage fully described, the remaining solid anatomy lectures on the thorax will deal with the thoracic viscera and other structures within the cage.
All right, it's time for another clinical correlation. Now, some of the landmarks and structures that were discussed in this lecture should be considered when placing a needle for a thoracentesis. So what is a thoracentesis anyway? Well, this is a procedure done to take a sample of the pleural fluid, which is found between the pleura and the thoracic wall, by passing a needle through an intercostal space. Now, there's normally just a small amount of pleural fluid filling the potential space between the lung and the thoracic wall. Now, this procedure is done to sample that fluid and to help with a diagnosis, or it might be done for a therapeutic reason as well. So let's talk about the placement of the needle, and this is in order to avoid damage to the neurovascular bundle. Now, we just mentioned the structures of the intercostal space. A particular note is the order of structures running in the space. So along the underside of the rib is we use VAN, and that VAN stands for vein, artery, and nerve. Now, thoracentesis needles, or chest tubes for that matter, can be inserted at several intercostal levels. The side of the chest and location will vary kind of depending on the patient and the clinical situation. The most common area is at the mid-axillary line at the 5th to 6th intercostal space. So let's just say that you're palpating a patient's rib. You palpate the rib, you have the patient lean forward in advance or walk the needle along the superior aspect of the rib, and you'll be pointing the tip of the needle toward the head. You insert it at or below the level of the fluid that you're trying to sample. Now, complications of this procedure are a pneumothorax. That's a big one. This may occur from a needle that's lacerating that visceral pleura, going a little too far. Now, this happens if you're pretty overzealous with your needle, and is more likely when you're taking your sample from a more superior intercostal space. In the elderly, it can be easy to nick an intercostal vein, even if you have otherwise placed your needle in a great position, so you might get some bleeding. Now, after taking the fluid sample, have the patient take a deep breath and then hum while you're removing that needle. This maneuver will increase the intrathoracic pressure and decreases the chance of a pneumothorax. All right, so let's go over a few of these questions. So when performing a thoracentesis, along what aspect of the rib do you advance the needle in order to avoid damaging the neurovascular bundle? Remember, you're inserting the needle along the superior aspect of the rib, with the tip of the needle pointing toward the patient's head. And then here is what is the usual intercostal space and location for a thoracentesis. Remember, that's the 5th or 6th intercostal space, mid-axillary line. So that covers the thoracic wall. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those questions together. All right, let's get going. First question, where is the second intercostal space located? Where is the subcostal space located? So all intercostal spaces lay below the rib. So for example, the second intercostal space is below the second rib. The subcostal space is found below the 12th rib. Next question. What is the name given to the ventral primary rami in the thoracic region? That's going to be the intercostal nerve. Next. In the thorax, when the sympathetic fibers leave the ventral rami to join the sympathetic trunks, they pass through what kind of connections? These are going to be the white rami communicans. Next question. Postsynaptic sympathetic fibers pass through what kind of ramus to reach the target organ? That's going to be the ventral ramus. Next question. Where are the hemizygous and the accessory hemizygous veins located with respect to the thoracic aorta? This is going to be left of the aorta. Next question. The greater, lesser, and least splanchnic nerves carry what kind of preganglionic nerve fibers? That's going to be sympathetic. Okay guys, we're almost done. Now we've provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your examination. So label the images and then we'll be done. Thanks.